Greetings from the United States of America. My name is Scott Oliver. I'm the head of ocular oncology at the University of Colorado. It's my pleasure to speak with you today about retinoblastoma. I will speak about the general aspects of the disease, and my colleague, Dr. Dave Cumpy, will share with you the remainder of information about intraarterial chemotherapy. I have no financial conflicts of interest in the material presented here. I'd like to begin with a case. This is one of my favorite patients, an 11-month-old little girl whose parents came to me feeling that she couldn't see. In fact, her eyes had been shaky for 3 months. The tumors had been filling the eyes. And on workup, she had an ICR group E tumor in the right eye, group D in the left. This is a very advanced case with an ominous prognosis for any recovery of vision. She underwent chemotherapy, and after 3 rounds, you can see marked reduction in the size of the tumors with calcium formation where areas of tumor have died. However, we still have work ahead as the retina remained detached on the left eye. After completion of 6 rounds of chemotherapy with vincristine, etoposide, and carboplatin, we thought we had the disease under control. However, she developed vitreous seed recurrence, very common in these advanced tumors. She underwent 6 months more of chemotherapy. After multiple laser sessions, we eventually achieved complete remission of the disease. She had a total of 19 exams over her 3-year treatment course. She now comes to see me as a 5th grader. She's in complete remission, and her vision returned to 20/70 in the right eye, 2100 in the left. This is what she looked like after we got control of her disease. Retinoblastoma is the most common primary eye cancer in children. It ranges widely in severity, from easily controlled tumors up to terribly advanced disease. There is no racial, gender, or predilection by side. The only risk factor for spontaneous retinoblastoma is advanced paternal age and poverty. Retinoblastoma is one of the great success stories in pediatric cancer. At major centers worldwide, survival is 95% or greater. We estimate about 200 to 300 cases per year in the United States. Globally, that number is estimated to be in the 6,000 to 9,000 range. It's about 2% of all cancers. This Kaplan-Meier plot shows progression through the 70s, 80s, 90s, and 2000s with increasing survival rates exceeding 95%. There now exists a large consortium of centers who share and compile data as well as clinical outcomes registries in order to maximally improve our management of this disease. It's truly a global disease, but it's rare enough that it requires cooperation around the world for us to be able to achieve advances in saving lives and saving sight. As I talk about the ocular aspect of the disease, I'd like to begin by reviewing the anatomy. The orange portion shown here is the retina. It's about the posterior 2/3 of the eye. Retinoblastoma originates in the retinocytes, which continue to divide and develop in the first couple years of life. When I look in the eye, I have this view, looking at the optic nerve, the macula, and trying to detect small white tumors that may signal recurrence or origination of a new tumor. Many of the treatments that we perform are done with direct visualization through the cornea and lens, so it does not require imaging at every step along the way. One additional area that's very important to inspect is the pineal gland using neuroimaging, as pineal blastoma can occur in the genetic form of this disease. Most children who present with retinoblastoma show up with leukocoria, or a white pupil. This is because the tumor obscures the view to the rest of the normal retina. Now, other things can cause leukocoria, but retinoblastoma should be the top of any pediatrician's list. If the tumor is large and it obstructs the view to the back of the eye, causing vision loss for the child, the eye will wander and turn either in or out. This can cause strabismus. It's very important for anyone taking care of retinoblastoma to remember the genetic aspects of this disease. Nearly every case is caused by a mutation in the RB1 gene, detectable if it's a sporadic case just inside the eye, and if it's germline, it's detectable in the peripheral blood. If a patient harbors the germline mutation, this is passed in an autosomal dominant fashion. And thus 50%, nearly 50% of offspring carry the chance of developing the disease. If it's sporadic, this is the prototypic disease for the random two-hit hypothesis, as both copies of the RB1 gene are knocked out. Now, if disease is present at multiple locations inside the eye, or if it's present in both eyes, de facto, we know that it is a germline mutation. However, unilateral disease does not tell us that whether or not it is the heritable form. Genetic workup is required. Amongst the cohort of eyes I have treated, about 60% are unilateral, but amongst the germline disease, a quarter of them were unilateral. So again, if it's bilateral disease, we know it's the heritable form, but unilateral disease still requires genetic evaluation and workup. People with the RB1 mutation carry a lifetime risk of other cancers as well. And it's very important to warn families of this, even after completion of treatment. Workup for retinoblastoma begins with a staging exam under anesthesia. We look inside the eye, carefully documenting the presence and size of tumors, taking photographs of the eye, and using ultrasound to confirm presence of calcification. Neuroimaging is essential. This helps us to know if the tumors invaded the optic nerve, as well as to look at the pineal gland. CAT scan is strongly discouraged. The reason? If a patient harbors the RB1 mutation and they receive radiation, the risk of secondary cancers climbs. Typically, the diagnosis can be made without the need of CAT scan. So when in doubt, get an ultrasound, get an MRI, and talk to a good ophthalmologist. Try to avoid external radiotherapy. As we talk about this disease, it's very important to have a good classification system. The ICRB is the standard one used at most centers worldwide and ranges from rather minor at group A up to very advanced disease, group E. These group A tumors here are small, easily managed with laser alone and not requiring sophisticated chemotherapy. As tumors get larger or involve the visual axis, they'd be classified as a group B. Group C tumors can have small adjacent seeds and small amounts of subretinal fluid, but again, carry a very high success rate, greater than 90% at saving the eye. It's the group D and group E eyes that present the largest challenge in the management of this disease. These patients have very advanced tumors that often have extensive retinal detachment, vitreous seeding, and sometimes infiltration of other ocular structures, such as the anterior chamber. Examination must be meticulous, and a good ophthalmologist is essential. This is a patient that we knew carried the gene who was in for a screening exam. And on initial view, this looks like a normal fundus. However, there's a tiny white tumor here. And on cross-section with an OCT laser, we can see the very earliest origin of a retinoblastoma tumor. Amongst patients at my center, note that greater than half present with advanced group D and group E eyes. This is because children do not complain about vision loss. Often the group A, B, and C eyes are second eyes in children with bilateral disease. Now, treatment modalities follow several overall strategy categories, and I'll go through those. Enucleation still is a very viable option, particularly for unilateral disease. External beam radiation is used at some centers globally, but has fallen out of favor in the United States because of the increased risk of secondary cancers. Brachytherapy or implanted radiation is appropriate in some cases. Chemo reduction is the mainstay of our treatment methodology for most inherited or bilateral disease. The patient undergoes 6 rounds of chemotherapy and local therapy to follow. In the last decade, intraarterial chemotherapy has seen a significant increase in utilization as a method with slightly higher success rates for advanced disease. Irrespective of the treatment strategy, local treatment control techniques are still essential, including cryodestruction, laser, and intravitreal chemotherapy. Laser photocoagulation is applied by the ophthalmologist, using laser of various wavelengths to be able to burn tumors. This works well for group A and B tumors, but less well for the more advanced ones, and thus requires the adjunct of chemotherapy. Here's a picture of well-lasered tumors that form flat scars with no visual consequence, and this patient will do well. Enucleation is still appropriate and is utilized in many instances for very advanced, particularly unilateral disease. It is curative. Now, many patients' families are now wishing to try to preserve the eye, and for that reason, we have begun to use intraarterial chemotherapy to try to salvage the globe. External beam radiotherapy was one of the initial treatment strategies for retinoblastoma decades ago because the tumors are very radiosensitive. It's now reserved for only the most severe, most advanced cases that have failed all other treatment regimens. The reason? Use of external beam radiotherapy often doubles or worse the risk of secondary cancers later in life. Brachytherapy, or local implantation of radiation, may be utilized for select tumors that are large enough, like a group B or C, that are in the optimal location. But it's chemoreduction with a 6-cycle round in the United States with vincristine, etoposide, and carboplatin that has accomplished excellent success in terms of survival and preservation of many eyes. The group A, B, and C eyes have greater than 90% globe salvage rate. We do see that drop off in the group D and group E group. Complications are generally minimal and well managed. Neutropenia is transient, as is hair loss. Ototoxicity has to be monitored. The carboplatin can cause hearing loss. However, the limitations are this does not work very well with vitreous seeds. It does not fully kill the tumor. It only shrinks them, which requires then intense laser to be able to manage the remainder of the tumor control. This is a typical case of chemoreduction followed by laser with excellent tumor necrosis. This is a more advanced eye, which you can see shrank and looked pretty good, but ultimately this group D eye was lost due to recurrence from those small tumors. Vitreous seeds are very difficult no matter the methodology. These have to be managed with intravitreal chemotherapy. Typically, the agent used is melphalan, and techniques now allow for excellent salvage of eyes with vitreous seeding. Intraarterial chemotherapy has been around for decades. Your specialty has been able to cannulate the ophthalmic artery for a long time. This allows us to apply a far more toxic and far more effective chemotherapy agent, typically melphalan, sometimes topotecan or carboplatin, and it has increased the globe salvage rate to about 85% for group D eyes and greater than 65% for group E eyes. So primary indications include advanced unilateral retinoblastoma, group D and E, select unilaterals that are not treatable with other methods, or tandem therapy, that is treatment of bilateral disease, but caution must be exercised as complications can result in loss of vision. I use it a lot, or recommend it a lot, for salvage treatment upon failure of traditional chemotherapy. When used as salvage, there's a higher risk of complications as well as failure. Dr. Cumpy will go through the details of application of the technique. And here's a nice example of an eye that was treated successfully with intraarterial chemotherapy. For infants younger than 3 months of age, the ophthalmic artery is too small to cannulate. These children can be bridged with traditional intravenous chemotherapy and subsequently treated with IAC. Complications of IAC are not insignificant. Commonly, we will see ptosis or droopy eyelid, redness and swelling of the lid. But the more severe complications are due to the toxicity of the drug, which can wipe out the vasculature in the back of the eye, and sadly, in some cases, despite controlling the cancer, result in blindness. Cataract is also something that we see commonly, along with vitreous hemorrhage and scarring, or inflammation inside of the eye. Why does the vasculopathy occur? Well, this is still under investigation, but we know that it's due to endothelial cell toxicity. My early experience with IAC came from referring patients to other centers. And out of the 8 eyes that I sent to well-known locations throughout the United States, 5 of those children wound up either blind or without an eye. Most of this was due to complications of the therapy, and I sat down with Dr. Cumpy to discuss beginning a program, which we did in 2016. Since then, we've performed 46 IAC procedures in 17 patients and completed 43 out of the 46. No metastasis or death has occurred. No children have suffered stroke. Transient complications have been easily managed. Only 1 patient sustained choroidal vasculopathy and loss of visual potential. 13 out of the 17 eyes have been saved. Those that were lost were very advanced tumors to begin with. It's critical to emphasize that you need a good team to manage this disease, including medical oncologists, neuroradiologists, pathologists, and interventional radiologists. Thank you very much for the invitation and the opportunity to talk to you about retinoblastoma.